Here are some notes on non-obstetric surgeries during pregnancy. There are some risks to the fetus during non-obstetric surgeries: maternal hypoxemia, hypotension, acidosis, and hyperventilation that can lead to alkalosis. In addition, fetal loss, preterm labor, growth restriction, low birth weight, and teratogenicity. There are some important interventions that you should make starting at around 18 to 20 weeks. Aspiration precautions, this could be with H2 blockers and nonparticulate antacids. Left uterine displacement to prevent aortocaval compression. And for preterm labor, you could use beta-2 agonists, calcium channel blockers, and magnesium as tocolytics. To reduce the risk of fetal complications during laparoscopic surgery specifically, you want to use lower insufflation pressures, such as 10 to 15 millimeters of mercury. This prevents a decrease in uterine perfusion. You also want to maintain a mild hypocarbia with an end tidal of 32 to 36 to prevent fetal acidosis, because you have an increased PaCO2 to EtCO2 gradient during insufflation. So because you know you're going to have an increased gradient, you can get a little bit of hypocarbia going to prevent that acid from building up, to prevent too much acid to the fetus. The surgical timing is something to consider. It's best to defer elective surgeries until after delivery, and the second trimester has the lowest balanced risk. In the first trimester, you have the highest risk of abnormal fetal organogenesis, and in the third trimester, you have the highest risk of premature labor. Some notes on medications. There are some medicines that we should avoid. These are based on animal studies. Benzodiazepines, especially midazolam, cocaine, nitrous oxide, especially for long exposures or high concentrations. Esmolol can cause fetal bradycardia, and ketamine over a certain dose in the first 2 trimesters can cause uterine hypotonus.